Hey guys, good morning. Let's enjoy the chest radiographs with Dr. Y. Posterior, paravertebral, mediastinum. And the last session of mediastinum. Session 26, paravertebral compartment of mediastinum. Let's go. This is the sagittal CT image diagram showing the paravertebral posterior mediastinal compartment. This yellow zone is paravertebral compartment. Today I'll talk with you about the disease occurring here in this yellow zone, paravertebral compartment. In this actual CT, the paravertebral compartment is from behind 1 centimeter of vertebral body anterior portion to the distal area of spine. This yellow-colored zone is paravertebral compartment, previously known as posterior mediastinum. Boundaries of paravertebral compartment is, let's go directly to the posterolateral boundary. That's vertical line against the posterior margin of the chest wall at lateral margin of transverse process of thoracic spine. A little bit long sentence, isn't it? What are there? The contents of paravertebral compartment. A. Thoracic spine. B. Paravertebral soft tissue. Pathologies of visceral compartment. Neurogenic tumor. Neurogenic tumor is the most important and the most common pathology of visceral compartment, and also one of the most important and most common disease of whole mediastinum. And the others are lymphoma, primary bone tumor, bone metastasis, spinal infections such as bacteria or TB spine, and cystic lesions such as meningocele, neuroenteric cyst, and extramedullary hematopoiesis. When we are looking for the paravertebral compartment lesions on chest radiograph, let's just focus on round ovoid mediastinal mass. B. Bone changes such as benign pressure erosion or enlargement of neuroforamen. C. Paraspinal stripe obliteration, especially on left side. D. Descending thoracic aorta line. E. Hilum overlay sign. F. Cervicothoracic sign. G. Thoraco-abdominal sign. Let's preview some facts about the neurogenic tumor. Neurogenic tumors are smooth, round to oval mass in paravertebral compartment. Most common feature is like that. B. Typically benign peripheral nerve sheath tumor. For example, schwannoma and neurofibroma. And up to 80% they are benign in nature. And 20% of adults and 35% of child mediastinal tumors are neurogenic tumors. E. Peripheral nerve sheath tumor usually from spinal and intercostal nerves, and then in small amounts and vagus, recurrent laryngeal and phrenic nerve origin. Let's start case number 1. This is a frontal chest radiograph of a middle-aged woman. There is a 7 cm well-defined margined mass, right upper lobe or mediastinum, homogeneous, well-defined margin. And there is another findings here. Benign pressure erosion, not destruction of spine, vertebral body. And we don't see the bone destruction, rib destruction, such as when we see on superior sulcus tumor. We usually see that findings on superior sulcus tumor, but we do not see here. And the mass upper margin is above the clavicle. Clavicle. What is this? Let's look at these two axial contrast enhanced CT. Upper portion is like this. We see a neuroforaminal enlargement with bone erosion, and there is soft tissue mass here on the right side. Neuroforamen enlargement with erosion. And the mass is well-defined round mass, compressing mediastinum, not destroying, not invading, not such bad looking, just compressing the mediastinal structure with slightly heterogeneous enhancement here. Yes, posterior paravertebral compartment neurogenic tumor, schwannoma. This is schwannoma. Case number 2. This is CT scanogram, not just radiograph. What do we see? Descending thorax aorta line is okay, no problem. How about paraspinal stripe? Yes. Bulging contour, well-defined margin, obliteration of paraspinal stripe. That famous sign of paraspinal stripe obliteration of neurogenic tumor and paravertebral compartment, about 3 cm in size. On this lateral film, something should be here, but not conspicuous here in this film. This is non-contrast enhanced axial CT. Yes, we see here 2 cm, well-defined, mediastinally broad-based in paravertebral compartment mass with small calcification. Aorta is okay, aorta line is okay, but this area where paraspinal stripe should be is obliterated due to this neurogenic tumor. Yes, neurogenic tumor in paravertebral compartment. Case number 3 with this middle-aged woman. What do we see? Well-defined round lung mass or well-defined half-moon-shaped broad-based mediastinal mass? Yes, let's look further. Right side heart border is preserved, well preserved, and right hilum, descending pulmonary arteries are okay. So, hilum overlay sign. This is not hilar mass. Maybe should be anterior or posterior to the hilum, not obscuring, not attached with the heart border. How about this lateral film? It's well behind the heart, posterior portion. Yes, round mass. If this is mediastinal tumor, it is paravertebral compartment neurogenic tumor. Or if this is a lung mass, right lower lobe superior segment round lung mass. What is this? This coronal CT shows paraspinally broad-based, heterogeneous, well-defined mass, that is, paravertebral compartment neurogenic tumor is possibility number 1. Yes. And on this axial image, this is broad-based on paravertebral compartment with well-defined margin. Yes, this is not lung cancer, but paravertebral compartment neurogenic tumor of schwannoma. Schwannoma is more likely to be heterogeneous after enhancement than neurofibroma. Neurofibroma is more likely to be homogeneous after contrast infusion. Let's look at the case number 4 of a young woman's frontal radiograph. There is a 4 cm well-defined mediastinally broad-based mass here, and half of the tumor is above the clavicle line, but the tumor itself is in the thorax, not extrathoracic in location. What this mean? On the lateral film, there is a mass here and the posterior compartment, paravertebral compartment. Clavicle level is about here. Yes, there is no space for mass in the anterior compartment to be located. Only posterior paravertebral compartment can afford a space for the tumor, mediastinal tumor. So, above the clavicle of a mediastinal tumor is surely paravertebral compartment. So, the likelihood is more likely to be neurogenic tumor. This is an axial contrast enhanced CT. Well-defined, clear-margined, mediastinally broad-based mass with stippled calcifications at the paravertebral compartment level. Yes, this is paravertebral compartment neurogenic tumor. Yes, posterior location. Have you ever heard the name cervical thoracic sign coined by Dr. Farson? Dr. Farson made this word for the lesion well above the thorax in cervical location overlying at the thoracic structure. That is cervical thoracic sign. That means not in thoracic location, but in cervical location. Now I think case number 5 is easy for you to diagnose. Yes, well-defined margin, mediastinally broad-based, almost same as the case number 4. Yes, on the axial contrast enhanced CT, paravertebral compartment, well-defined margin, mediastinally broad-based tumor. Yes, neurogenic tumor of paravertebral compartment. Sure. Let's enjoy the case number 6. It's an interesting case. And here comes the wonderful another sign of Dr. Farson, thoraco-abdominal sign. What do we see? Large, well-defined, mediastinally broad-based tumor. So, mediastinal tumor, not in contact with the heart. So, it should be in front of the heart or behind the heart. There is a little space for this large mass in the anterior portion. So, this should be in posterior compartment, paravertebral compartment, mediastinal tumor. And why this is in thoracic location, not in abdominal location? Let's see on the lateral film. Let's confirm why it's in posterior location. The diaphragm on the frontal radiograph is actually the continuation of the highest point of diaphragm here. This line is highest point of diaphragm, not all the diaphragm. So diaphragm is actually here and here. So the mass above the diaphragm line should be only in the thorax, but the mass below the diaphragm line also can be in the posterior thorax too. That is thoraco-abdominal sign. When this sign shows the mass is in thoracic location like this, not in abdominal location. The point is, the diaphragm, what do we see is the highest, only the highest point of diaphragm. Yes. With these two coronal and axial contrast enhanced CT, you can now easily, comfortably understand why this mass was looked like this on the chest radiograph. Yes, this is in thorax location. Actually, the diaphragm on the chest radiograph should be here like this, like this. That's why thoraco-abdominal sign is applicable here in thoracic location, especially posterior location. Diaphragm is here, yes. On this axial CT, it is the shape, the usual shape of paravertebral compartment mediastinal tumor. It was confirmed as teratoma, mature teratoma. Case number 7. Actually, this is a quiz for you and me. Let's enjoy the findings. This is not frontal radiograph. Let's start from left lateral film. Okay? Yes. What do we see? Large mass density. Posteriorly well-defined mass density. This shouldn't be here in normal person. Have you ever heard the retrocardiac triangle? Yes, this area should be clean. Have you ever heard the positive spine sign? Spine should be clean with spine only, not with something. That is positive spine. Something wrong with this. Which side of diaphragm is this? Yes, right side. Which side of diaphragm is this? Okay, left side. The mass is in contact with the left side diaphragm. This is inferior vena cava of right side. It is okay. So this mass is left lower mediastinal posterior tumor contacting with left hemidiaphragm. This is frontal radiographic. Does the findings concur with your imagination from the lateral film? Yes, very good. Heart border is preserved. That means in posterior location of mediastinal tumor. And aorta line is obliterated. Paraspinal line is obliterated. Also means posterior in location. And diaphragm is also obscured. That means in contact with the diaphragm. So this well-defined mass is left paravertebral compartment mediastinal tumor, well-defined mediastinal tumor. This CT axial findings explains everything what we have imagined with frontal two radiographs, right? Homogeneous, cystic, broad-based, mediastinal, paravertebral compartment, tumor, cyst, with aorta obliteration, paraspinal line obliteration. It was confirmed as bronchogenic cyst. This is the last case, case number 8. Actually, this kind of lesion is getting rarer and rarer, and in the future, we may not see this kind of disease anymore. The possibility is high because our hygiene and hospital system is getting better and better. Actually, at first, we mistakenly diagnosed this as enlarged left atrium with carotid widening. That was a mistake. That was not heart disease. Heart is okay. This is T-spine, dorsalumbar spine AP view. Yes, we see the low T-spine destruction, narrowed interspace with a bilateral paraspinal bulging with obliteration of a paraspinal stripe. This was TB spine, so-called TB spine, paraspinal tuberculous cold abscess. In this non-contrast enhanced axial CT, we see the vertebral body destruction, tuberculous destruction with large frontal bilateral continuous abscess, cold abscess, thin-walled cold abscess with bilateral pleural effusion and lung collapse. And this is sagittal dorsal-lumbar MRI showing what we have seen is this level. Yes, this is cold abscess with enhancing rim. This is cold abscess with enhancing rim. And she has another lesion in the lumbar area, lower lumbar. Yes, this is cold abscess with enhancing rim. Cold abscess. Yes, TB spine. This is one of the paravertebral compartment lesions. Not easy to see anymore. This is case number 9. Just enjoy the findings. There's a large mass here. Is this mediastinal tumor? I don't know. But we see many other variable-sized nodules, round nodules, may suggest hematogenous lung metastasis. On this lateral film, the largest mass is in the posterior location, broadly based posteriorly, medially, and with very many lung nodules, representing hematogenous lung metastasis. How do you feel about the findings with the axial contrast enhanced CT of this man? Is this paravertebral compartment neurogenic tumor? Lung metastasis? No. This is largest one of the hematogenous lung metastasis with round shape. Yes, confusing. It's confusing. But there are so many other variable-sized lung nodules here at the same time from the beginning of hematogenous metastasis. Just largest one of hematogenous metastasis is looking like paravertebral compartment neurogenic tumor. This is lung metastasis. Hey guys, we just finished all 4 sessions of mediastinal disease. How do you feel? Yes, very successful. I hope you and me all give big hands to ourselves and thank God we have good times. Like, subscribe will be a big support to Dr. Y. See you next time. Bye-bye.